Hey, good morning, everyone, and welcome to Euronurse. I'm your host, Vic Sinise, and we're going to be still celebrating Prostate Cancer Awareness Month with everybody. So let's get moving along with the show. If you're watching us live, welcome to the show, live viewers on all those different stations that we're coming to you from. If this is your first time checking us out, be sure to go to our website at euronurse.com, the best place to go to learn more about the show. Also, the best place to go to watch all of our past 110 past episodes, that is. We've been doing this now for over 2 years. If you want to listen to us in our car, wow, that's taken off like crazy. I've noticed how many podcasts have gone out on the audio. So, hey, listen to us in your car. Go to our Euronurse Plus area. It'll bring you to any of your favorite podcasting formats. And a little shout out for a couple of weeks from now. The Euronurse group, the experts, are going to be at the SUNA conference on September 28th, and we're going to be live. We're going to have our show going off live. It'll be 10 o'clock Eastern time, 9 o'clock Central time. But join us a half hour early for a meet and greet. Come and see us, talk to us. I'm going to have a couple of things that we'll be giving away, some Euronurse merch, so be sure to join us. And hey, the foundation, the SUNA Foundation, they do a lot of great work. Be sure to support them. There's an online raffle going around. It has a $300 Amazon gift card that was donated by the Chicago Metro SUNA chapter, one that all three of these experts are from. Also, there's a great foundation event. So lots of ways to get involved with the foundation, but most importantly, donate. Now, this week, we're going to be continuing, as I said, with our prostate cancer awareness. All subjects of prostate cancer this month. And we're going to be talking about refining PSMA testing in prostate cancer, next generation strategy, imaging strategies. It's really cool. We've had a talk on this in the past, but this one is presented by a urologist and a radiologist. It is a little on the long side, so we're going to go right into our episode. I'm going to start up the film going for you, and you can get your contact hour at the end. I'll have that link up shortly after the show. So no experts today because, like I said, we're going to fill up the show with this particular show, and let's get going.
Welcome to Refining PSMA Testing in Prostate Cancer, Next Generation Imaging Strategies, presented by Partners for Advancing Clinical Education in collaboration with the Large Urology Group Practice Association at medlive.com. My name is Dr. Jason Hafron, Chief Medical Officer at the Michigan Institute of Urology and Medical Director of Research, and also Professor of Urology at the William Beaumont School of Medicine. I'd now like to introduce my co-presenter, Dr. David Schuster, Professor of Radiology and Imaging Services and Urology, the GRA Distinguished Cancer Scientist, and Director of the Division of Nuclear Medicine and Molecular Imaging in the Department of Radiology and Imaging Sciences at Emory University.
Thank you,
David. Yeah, thanks, David, for joining today. We have a great program. Here are our relevant disclosures. So here are our objectives. Today, we want to describe the role of PSMA as a biomarker for prostate cancer. We want to evaluate current and emerging radiotracers for PSMA imaging, including standard and hybrid radiopharmaceuticals. We also want to evaluate and look at utilized radiotracers for PSMA PET CT imaging in appropriate patients with prostate cancer. Let's talk about PSMA testing in prostate cancer. I think it's important to understand PSMA testing in prostate cancer is to evaluate where we've come from and evaluate the historical challenges of imaging in prostate cancer. Prostate is a unique solid tumor in that up to recently, we had very limited imaging capabilities to routinely detect and localize this disease. The use of serum PSA in clinical practice has resulted in a significant stage migration, and such imaging modalities historically used to stage prostate cancer are no longer reliable to identify the small amounts of prostate cancer that we are detecting in the current day and age. Historically, the diagnosis and management of prostate cancer was largely based on serum PSA, pathologic risk factors as Gleason, and clinical stage. So why is imaging important for staging? Historically, as I said on the previous slide, patients undergoing potentially curative surgery or radiotherapy for prostate cancer have experienced a profound shift towards earlier stage disease. As such, in most patients, the ability to accurately stage the disease prior to therapy has become much more difficult. Treatment at lower PSA and disease volume inherently implies a much lower likelihood of demonstrating metastatic disease on conventional imaging, and I'll show you the data to support that. But early diagnosis, proper risk classification, and an accurate staging of prostate cancer are necessary to plan the most appropriate treatment strategy. It is clearly desirable to accurately stage prostate cancer patients prior to therapy. These are kind of obvious to maximize the likelihood of treatment efficacy. And secondly, offer multimodal treatment strategies to patients at a high likelihood of treatment failure. And this is why I'm going to make a pretty bold statement here, is CT and bone scan are no longer adequate for staging. I think the gold standard has been passed, and Dr. Schuster is going to show you some data, but I want to start this discussion to look at what we've used historically: conventional imaging, bone scan, and CT scan. If you look at bone scan in a meta-analysis of 23 studies evaluating bone metastasis, bone scan identified metastasis in 2.3, 5.3, and 16.4% of men with PSA levels less than 10, 10.1 to 20, and 20 and above, respectively. Albertson and colleagues reported that the yield of bone scan exceeded 10% in only individuals with a PSA greater than 50, or a Gleason 8 to 10 and a PSA greater than 20. When you look at CT scan, a fundamental shortcoming of CT in detecting lymph node metastasis is its inability to detect architectural changes within normal size, less than 10 millimeter lymph nodes. We know that prostate cancer can exist in lymph nodes that are much smaller than 10 millimeters, as most surgically detected lymph node metastases are microscopic in contemporary series. The sensitivity of CT scanning is significantly reduced. In a review of 25 studies, CT was found to identify lymph node metastasis in 0% of men with a PSA less than 20 and in 1.1% with a PSA greater than 20. PSMA testing is confirming what we thought about prostate cancer. If you look in the non-metastatic castration-resistant prostate cancer population and they undergo PSMA ligand PET CT, they find local regional disease in 44% of those patients and distant metastatic disease in 55% of these patients. These patients had conventional CT bone scan that were negative. Many patients in previous literature with high-risk localized disease were probably oligometastatic. If you look at the STAMPEDE H arm of patients with de novo oligometastatic disease, there was a 10% improvement in 3-year overall survival from patients that underwent local radical radiotherapy in addition to systemic treatment compared to those who received systemic treatment alone. The point of this is that we always have known that there's probably micrometastatic disease, but prior to PSMA PET testing, we couldn't find it. No longer is CT and bone scan adequate based on the stage migration, as well as how we are finding these patients today. Stage does matter, and you look at the 5-year relative survival rates depending on stage of diagnosis. Localized and regional disease has a nearly 100% 5-year survival. Distant metastasis 5-year survival historically, and this is based on SEER data, is about 30.2%. So with that being said, you really want to know their current stage at diagnosis so you can appropriately treat them, whether it's a tumor intensification, treatment intensification. We have to treat these patients more appropriately based on the extent of the disease, which is given to us by the PSMA PET scan to really stage them as best as we can. So the rationale for advanced imaging: PET agents can identify changes at the cellular level, i.e. changes in tumor cell function rather than tumor size. Like I said with the lymph node, the only reason that we say lymph nodes are positive is just based on their size, when actually we're not really measuring what's going on within the cells, and that's what PET imaging does. The same thing is true for bone. When you look at a bone scan, you see secondary effects of the tumor. You're not truly measuring the cancer and at the cellular level, and that's essentially what PSMA PET is doing, and it does it at a much higher level. Current prospective evidence underlies the role of PSMA PET for prostate cancer in initial staging for unfavorable and high risk, and demonstrates superiority over conventional imaging. A lot of this data we'll walk you through over the next hour so that you will understand how we can make such strong statements. And the key to PSMA imaging is the target, and that's the prostate-specific membrane antigen, the PSA membrane antigen. It's a type 2 transmembrane glycoprotein. Thankfully, it's overexpressed on the cell surface of 95% of prostate cancers. It increases with higher grade, with metastatic disease and hormone refractory cancer. So we have a great target. The key why PSMA is better than the previous prostatine scan is it's extracellular. It's sticking outside the cancer cells, and it's overexpressed on the cancer cells, making it a great target for diagnosis as well as potentially treatment. So currently, where we're using PSMA PET imaging is initial stage of prostate cancer. We'll go over the specifics and what the guidelines say. Localization of recurrent BCR and prostate cancer. We'll go over the guidelines and have some great cases to explain, and Dr. Schuster's going to go over the data. And then staging before PSMA-directed radioligand therapy, that's a requirement. It's also exciting to measure, to look at what's the future of this, and we're seeing some initial studies that look in guidance of prostate biopsy, monitoring of systemic treatment for metastatic prostate cancer, and the UCLA group under Dr. Reiter has done some interesting studies on intraoperative identification of lymph nodes. Not stuff we're really going to talk about today, but I think the message here is that PSMA PET is very powerful tool, and it's going to continue to grow and be a strong part of a urologist tool chest. That being said, reason why I can make bold statements and say that, the gold standard is being passed by PSMA is there's been some solid studies, including Pro-PSMA, Osprey, Lighthouse, UCLA, and UCFF have done some awesome, outstanding work to show that it's more sensitive, more specific, more accurate. And it also is nice that it's reproducible. There's not much inter-observer variability when looking at these trials. I'm going to leave that to Dr. Schuster, and I'm going to turn it over to Dr. Schuster to talk about the various radiotracers that we're using for PSMA imaging today.
Thank you, Jason. So let's talk about what is a radiopharmaceutical. Think of this as a missile directed against a target. Our target here is PSMA, as we have been shown. And that missile contains a payload, which is a radionuclide. That radionuclide can either give off diagnostic radiation, or it can give off therapeutic radiation. In other words, used in a PET scanner to localize the disease or to treat the disease. Sometimes it's a little bit of both, but we won't get into that much of specifics. So there are a growing body of radiopharmaceuticals that target PSMA on the surface of prostate cancer cells. And there are a number of FDA-approved PSMA radiotracers. These include gallium-68 PSMA-11, F-18 piflufolastat PSMA, also known as DCF-PYL, F-18 flotofolastat PSMA, also known as rh-PSMA 7.3. As far as gallium-68 PSMA-11, this was approved, the earliest one in the United States, in December of 2020, but there are a number of other commercial preparations which had subsequent approval. So the FDA-approved indications are for men with suspected prostate cancer metastasis who are potentially curable by surgery or radiation therapy. Essentially, this is the higher risk primary prostate cancer. Then there is the recurrence, suspected prostate cancer recurrence based on the standard definitions of elevated PSA post-therapy. It can also be used to select patients for lutetium-177 PSMA-directed therapy, currently in patients with metastatic castrate-resistant prostate cancer, based on the data from the VISION trial. And these are administered in the form of an intravenous injection. So let's discuss the PRO-PSMA trial, which was a trial out of Australia. This is a multi-center randomized two-arm clinical trial of 302 patients, which directly compared staging with conventional imaging, that's CT plus bone scan, versus PSMA PET CT as first-line imaging in patients with high-risk prostate cancer using the standard definitions. And here we can see that the specificity is about the same, but the sensitivity is much greater with the PSMA PET in red. So overall, there's a 27% greater accuracy when compared with CT and bone scan for staging of initial high-risk prostate cancer. And PSMA PET is superior to CT and bone scan in detecting lymph node metastasis and other lesions with, again, a significantly higher sensitivity, but not at the expense of specificity. In fact, specificity is even higher. Also, there were fewer equivocal lesions with PSMA PET versus conventional imaging. And in general, though some of this is dependent on the exact PET-CT technique you're using, there is a higher radiation exposure utilizing conventional imaging. And these findings were validated by a composite standard of truth, including histopathology imaging or follow-up at 6 months. So as far as biochemically recurrent prostate cancer, there have been a number of studies. Gallium PSMA-11 in this study was utilized in 2005 patients with elevated PSA after initial therapy. And it's shown that gallium PSMA PET at 3 institutions had a high positive predictive value with, of course, greater detection rate at a higher PSA level. And I'm going to show some slides of that as well. Now, I should mention also fluorinated PSMA, and we're going to discuss this a little later on also. But in terms of fluorinated PSMA, Dr. Marty Pomper at Johns Hopkins developed an early iteration called DCFBC, which we could see at the top, had a lot of blood pool, and continued working on this. And this led to the second generation low molecular weight fluorinating PSMA called DCFPYL. And that is what has been FDA approved. So let's talk about DCFPYL, or piflufolastat PSMA. This was approved in May of 2021 as the first fluorinated PSMA radiotracer in the US. The indications are similar to gallium PSMA-11. These are staging patients with a higher risk for initial therapy with biochemical recurrence, and as accepted by NCCN guidelines, this radiotracer can also be used to qualify patients for lutetium-177 PSMA therapy. So though it's not on the package insert, NCCN panel believes that it's close enough that one can then qualify patients for this indication. So we're going to talk about the 2 registry trials for DCFPYL. First is OSPREY. And for all practical purposes, this data was for the higher risk primary prostate cancer, though there was also an arm looking at recurrent disease. But essentially, 252 patients had an evaluable PYL PET-CT scan, and then went on to get radical prostatectomy and lymph node detection. And the primary endpoints here were sensitivity and specificity in detecting lymph nodes. And then we can see kind of a common theme when we are comparing imaging versus histologic standard in this case. The sensitivity is about 40%. That's not surprising because there is no way that imaging will be, for the foreseeable future, as sensitive as the pathologist examining that lymph node and finding microscopic disease. But the specificity is very high and much higher than conventional imaging. And as we'll show in a later case, this can be used to guide the urologist to fine-tune the surgery. Also, there was a nearly threefold higher positive predictive value than conventional imaging, with higher negative predictive value and specificity. Next, we have the Condor trial, which was the registry trial for recurrent disease. So 208 men with biochemical recurrence, by the standard definitions, were imaged. And they had a negative or equivocal conventional imaging first. The primary endpoint was designed by the FDA, called the correct localization rate. For all practical purposes, this is positive predictive value. There were also a number of secondary endpoints, including change of management. Here we can see that the overall detection rate was quite good, and it also varied with PSA. So the higher the PSA, and the different color bars are the three readers, then we could see that when we start with a PSA less than 0.5, just under 40%, which is actually really good compared to what we've historically had. And then further up thereafter, for example, with a PSA greater than 5, we go up to 96%. Now, this is what we call the raw detection rate. Next, we have the correct localization rate, which again can be thought of as positive predictive value. With a PSA less than 0.5, quite high, 73.3%. And as the PSA goes up, we could see that correct localization rate rises as well to 96.4% with a PSA greater than 5. There was also showing a great change in management. And this occurred whether a patient had a negative or a positive PET. So 131 patients, or 64%, had a change in management based on the results of their PYL. Now, these were a combination of major changes and minor changes. But as we could see here, for example, we had 28% who had salvage local therapy initially planned that was then supplemented or replaced by systemic therapy, mostly because more extensive disease was discovered, or going from planned observation to initiating therapy, systemic therapy, then switched to salvage local therapy, or planned treatment to observation. So we can see that there was a great change in both directions of management. And again, 79% of the changes were after a positive PET, but even a negative PET caused a change in management. So overall, in multiple studies, for example, in this, these two phase 2-3 multicenter trials, PYL and gallium PSMA-11 demonstrated high specificity for detection of pelvic lymph node metastasis in individuals with intermediate or high risk prostate cancer undergoing radical prostatectomy. In this way, they were significantly superior to CT scanning. And of course, we want to use this in the correct patient population. And this is essentially thought to be unfavorable intermediate risk or higher. Though if patients have symptoms, sometimes one may want to get a scan earlier. But there are other ways to skin the cat, as we say, in terms of radiotracers. And this is the introduction to radiohybrid molecules. So radiohybrids are monozygotic chemical twins. And in this case, we could see that both molecules to the left and right have that PSMA ligand. So their target is still PSMA. But on the left, where we have the molecule constructed for imaging, we have what we call a cold metal, but a hot fluorine. That fluorine 18 gives off the positrons and then the high energy photons after annihilation that we see on the PET scan. But we can also then have a hot metal, like in this case, lutetium-177, and a cold fluorine, in which case we use this for therapy. So these radiohybrids exhibit nearly identical affinity, selectivity, lipophilicity, and pharmacokinetics as compared to other theranostic pairs. Again, it's kind of like having twins, but just with different toolkits. So this is the introduction to this new class of PSMA-targeted PET radiopharmaceuticals based on this radiohybrid technology, and the latest to be FDA approved, called flodufolostat F18. There is high PSMA binding affinity, high internalization by PSMA expressing cells, medium to low lipophilicity, and high human serum albumin binding. What does that mean? That means that altogether there's lower urinary excretion than we see with the other two motifs like gallium PSMA and PYL. And why is that important? Because sometimes high bladder activity will mask lesions close to the bladder, such as in the prostate bed. So again, this was the first radiohybrid agent to be approved in May of 2023. Same indications as we see for the other fluorinated PET radiotracer. So let's talk about the two registry trials. The first was for primary prostate cancer, using that appropriate population of unfavorable intermediate to very high risk. And this was called the Lighthouse study. Now, this used these standard definitions, so we won't go into detail on those, but all these patients had to be candidates for radical prostatectomy with pelvic lymph node dissection, and of course, scheduled to undergo such. The primary endpoint were sensitivity and specificity in detecting the lymph node metastasis using histopathology as the standard of truth. So the average for specificity was quite high, 95% across 3 readers. And again, we could see that same theme as we saw with other PET radiotracers. Here it was just a little bit lower. This probably due to the way that the study was designed, but the sensitivity was just under 30%. Again, putting imaging up against the pathologist looking for microscopic cells, the pathologist is going to win here. Importantly, extrapelvic, or what we call M1 lesions, were found, depending on the reader, in 16 to 28% of scans, and of the 352 patients with an evaluable scan, 10% had at least one matching positive M1 lesion, in other words, proved with the reference standard. So it could have actually been higher, but at least 10% had a metastatic lesion, which will change the approach to the patient. This is from the package insert, basically reiterating what we've just discussed. The take-home message here is that sensitivity is in line with other PSMA radiotracers, but the specificity is high to help guide the urologist. So if this is negative, we're not going to tell the urologist, don't do the surgery, because they're going to find microscopic disease we can't see with imaging. But we can help guide the therapeutic decisions, especially if a metastatic lesion is discovered, which then changes the calculus. That's metastatic lesion outside of the pelvic lymph nodes. Next is the Spotlight study, which is the biochemical recurrence type of registry trial, enrolling 391 patients with what we call a composite standard of truth with histopathology, imaging, and correlation, and other follow-up. Here we could see something very interesting, that one strength of this radiotracer is that there's a high detection rate even at low PSA levels. So remember, we saw earlier that the PSA less than 0.5 detection was maybe just under 40%. This was approximately 60%. And going up thereafter, PSA greater than 2, we have very high detection rate of 97%. Overall, all comers, 83% by majority read. And the take-home message here is there's a high detection rate across PSA levels. Detection, of course, varies with PSA. The higher the PSA, the greater the chance of detecting the disease. Now, this prospective study design was really only applying the standard of truth to positives. Patients with negative studies, you'd have to follow out for a long time to try to determine any composite standard of truth. So a negative study does not eliminate the need for clinical follow-up. In fact, we know if a patient has biochemical recurrence based on elevated PSA, there is disease there. And if we don't see it on imaging, it just means that the imaging is not sensitive enough to detect that small volume or microscopic disease. Now, if we look at the impact of management change, clinicians review treatment plans prior to and after 97 patients. This was a subset with recurrent prostate cancer. And again, both positive and negative flow-to-folostat scans influence patient management, but 89% of patients had treatment changes after PET scan, and what we consider major changes occurred with 80%, and this includes a negative scan who perhaps management plans were revised to watchful waiting if there wasn't thought to be a great burden of disease. There is an ongoing trial looking at the role of flow-to-folostat PET in patients with high-risk prostate cancer. So this is taking out that unfavorable intermediate and just looking at the high-risk prostate following conventional imaging. This is a phase 3B investigator-initiated trial, which is designed along similar guidelines as Lighthouse, but we'll look at sensitivity and specificity for detection of not only nodal disease, but metastatic disease with a subsequent evaluation of management changes. Again, this for the higher risk group. Patients will undergo conventional imaging, and then physicians will have to record in advance what the treatment plan would be. Patients then undergo the flow-to-folostat PET, and then the results are reported back to the responsible physician, who will provide a final written management plan, and then these will be compared. And also percentage of men who will be upstaged will also be analyzed as well. Now, here we come to a final point, which is as far as monitoring treatment for advanced prostate cancer. This area is not as well developed. And there is ongoing research with different, you might say, schema trying to incorporate PSMA PET, such as the PPP criteria or the RECIP1 criteria, not to get into too much detail. There's some overlap and there's some novel qualities of each of these techniques. But overall, when we're looking at a patient being treated with advanced prostate cancer, especially metastatic castrate-resistant prostate cancer, the old PCWG working group 3 criteria still apply, which use a combination of PSA, clinical, CT, and bone scan. But I have it on good authority that Prostate Cancer Working Group 4 will be coming along in the future, which will then incorporate PSMA PET as well. So in conclusion, PET imaging is a disruptive technology that is changing our understanding and management of prostate cancer. PET imaging is quickly becoming the preferred choice of imaging in men with prostate cancer. And as Dr. Hafron said before, the NCCN now recommend you should go right to PSMA PET instead of bothering with a CT or bone scan in most circumstances. And future studies will be necessary to demonstrate whether PET changes in management lead to improved outcomes for patients. And I'm going to hand it over back to Jason for strategies for PSMA testing in clinical practice.
Yeah, thanks so much, Dr. Schuster. That was an amazing summary of years of work, and just so many good nuggets in there to explain why this is disruptive technology. Looking at the performance of these tests, what's refreshing is that the guidelines are consistent and make sense based on the results of those trials that Dr. Schuster just presented. It's kind of funny if you compare the NCCN guidelines from 2012 to the most recent 2024. Over the last 12 years, they had no principles of imaging section in 2012. 12 years later, that has gone to 3.5 pages of principles and guidelines. Just shows how much this space has expanded and will continue to expand in the future. But again, like I said, the guidelines are pretty consistent with the trials. There's no, in my opinion, we'll find out Dr. Schuster's opinion in a minute, no really disconnects that I see as a practicing urology. Basically, PSMA is indicated for unfavorable, intermediate, high risk, and very high risk localized prostate cancer. And I think that in the verbiage of the footnotes, and I'm just going to read this. This is straight out of the NCCN guidelines. I think it's appropriate because of the increased sensitivity and specificity of PSMA PET tracers for detecting micrometastatic disease compared to conventional imaging at both initial staging and biochemical recurrence. The NCCN panel, does not feel that conventional imaging is necessary prerequisite to PSMA PET, and that PSMA PET CT or PSMA PET MRI can serve as equally effective, if not more effective, frontline imaging tools for these patients. So I think that's a very strong statement, and a very clear statement is that we are dealing with something that may be, or probably is, or based on the presented literature, is better than conventional imaging. And like sometimes or frequently our payers will make us get a CT bone scan, which is essentially, I think, a waste of resources. And you probably should just go to PSMA PET on the initial testing when you're staging patients with unfavorable, intermediate risk and above prostate cancer. Also, the important guidelines are appropriate use criteria, and this was developed by the SNMMI, or the Society of Nuclear Medicine and Molecular Imaging, and it's a guide to referring and imaging physicians to use PET imaging agents appropriately. There's a little bit different than the NCCN. It's kind of maybe more like a typical AUA guideline, but they've developed 12 clinical scenarios for prostate cancer, and they have kind of getting this appropriateness for those clinical scenarios. And these are, I don't see any, but we'll ask Dr. Schuster in a second, any really disconnect I don't see, and I'm just a urologist, but it seems like, again, in scenario 3, newly diagnosed unfavorable, intermediate, high risk or very high risk, PSMA is appropriate. It can be also a newly diagnosed with equivocal or oligometastatic disease on conventional imaging. So even if the conventional imaging is positive, you may want to get a PET imaging, something that, is a little bit more sensitive or definitely more specific to identify if those lesions are true positives. It may be appropriate in PSA persistence or PSA rise from an undetectable level after radical prostatectomy, or what we refer to as biochemical failure. PSMA PET is appropriate, and what I frequently use, and we'll show you some cases on that. PSA rise after nadir, after definitive radiation therapy or radiation failure, appropriate. And a patient with non-metastatic CRPC on conventional imaging, a PSMA PET works very nicely, and I showed you some of that data where it's detects disease about 50% of the time. And then it also may be appropriate, again, we mentioned earlier, in patients that are being considered for radioligand therapy, it's a requirement that they undergo PSMA PET imaging. So again, easy to read, obvious clinical scenarios where PSMA PET is appropriate and probably is beneficial. The general considerations, going back to the NCCN guidelines, which I use most frequently, I think most urologists do, is that it has increased sensitivity and specificity of PSMA PET tracers for detecting micrometastatic disease compared to conventional imaging, CT, and bone scan at staging and biochemical recurrence. Conventional imaging is not a prerequisite. That's in the guidelines. I frequently would love to tell the payers or the people approving this, there's no reason to order a CT bone scan. PSMA PET is a better imaging test. And per the NCCN, it's equally effective, if not more effective. Frontline imaging tools, this is right out of the guidelines, may be used for detection at initial staging, unfavorable and higher, biochemical recurrence, and progression of disease in bone and soft tissue. PSA imaging should be done before initiation of ADT because ADT may affect detection sensitivity. We're not going to discuss much of that, but there is some literature not well developed yet, but ADT does affect PSMA. And then there's some, as far as considerations, which we'll get into regarding the production of PSMA radiotracers, a generator versus cyclotron, regional versus national. So, I think we have a second, and I just want to, while we got Dr. Schuster here, is, what are your thoughts on the guidelines? Is there any real difference between what is being told to clinical urologists versus in the nuclear medicine world and the radiology world?
Yeah, I think these are very well aligned. And the guidelines, the AUC guidelines, are also being made with input from various societies, including urology. I think it's just a matter of difference in style and how they're presented. NCCN guidelines tend to be more algorithmic, right? And while the SNMMI guidelines are maybe they get a little more granular, and they give you kind of more different kinds of cases, and even they might use the term rarely appropriate, because we know in medicine it's really not a matter of never or always, right? So there's a lot of clinical decisions. So for example, the favorable intermediate, right? Normally, you wouldn't get imaging for that, but rarely you might have a patient who you have a clinical suspicion, and a strong clinical suspicion, and therefore it might be appropriate. So I think it's leaving a little more room for clinical judgment as well. But I think they're basically aligned.
Yeah, that's great points. Another question that comes up, Dr. Schuster, in clinical practice, after surgery, we may have an early failure. The PSA, we'll see at 0.17, 0.19, maybe a 0.2, following, a robotic prostatectomy. Is it ever too early to order a PSMA PET? What do you recommend to your urologist is when's the appropriate timing of PSMA imaging in a recurrent situation?
So I would say it's never too early, because radiation oncologists are treating disease at lower and lower PSA levels. And I think a lot depends also, was it a case of the PSA never coming down to nadir versus maybe it was at nadir for 5 years, and now you're seeing 0.01, in which case you probably, want to follow it with another PSA. So of course it depends on the situation, but I could tell you that we have seen even more distant metastatic disease with PSA less than 0.1. I'm not saying it's common, but it's common enough that if you're going to then treat a patient definitively, you should have all the information available to you. And these treatments, like radiation, are expensive, and ADT is not without harm to the patients, and it's also going to be expensive too. So I think now that we have these tools, they are excellent tools to use. But of course, it depends on the clinical situation.
No, that's great feedback, and we're finding the same thing. I mean, PSMA PET is changing how we treat this disease, how we look at this disease. We're finding, tumor sites in places we never thought were possible at this stage of disease. It's really been a disruptive technology that, in due time we'll have the studies to show it's improving outcomes, but clearly a very powerful tool. I want to, run through this slide, but really just ask you, as a urologist, selection of the modalities or the tracers, there's practical considerations, the cyclotrons, logistics, this is kind of more in your wheelhouse. How do you decide which tracer to use? As a urologist, is there any role for us to, recommend, or would we consider one tracer or the other? Talk to me about tracers and how you and your department decide what and when.
So I would say, as an end user, either the patient or the urologist or the radiation oncologist, I don't think this is something that you really need to concern yourself with. I think that a lot of this depends. We make enterprise decisions, especially in a big hospital system such as ours, and this is based on availability and being able to deliver, how easily we can get, and how conveniently we can get a certain radio tracer. So we might say that, okay, we're going to use this as our one, but in case of a synthesis failure, then we're going to use this other one as a backup. And what decision we might make in Atlanta, big city with multiple commercial radio pharmacies, may be different than one may make maybe in rural Montana, where there may not be as much availability, and having a local radio pharmacy with a generator, which could produce gallium-68, might be the best alternative. So I would say that the more important conversation to have is talk to your imaging specialist, and if PSMA PET's not available, I would ask why, and maybe start a conversation and say, okay, let's investigate these various, ways of doing this, and rather than getting into the weeds, and then, kind of maybe letting them make a decision based on multiple factors, including enterprise considerations.
So that being said, what are the pros and cons of fluorinated PSMA radio tracers?
Sure. So to go into basics, gallium-68 has what we call a 68-minute half-life. That means every 68 minutes, there is half the amount left. So it's something called physical decay. This is just something to do with nature and physics. So fluorine-18 has a 110-minute half-life, so nearly twice as much. So a pro of the fluorinated also, not only the longer half-life, but let's just say it boils down to better contrast and resolution. The images are, you may say, a little more detailed. And depending on the reader, I think the fluorine-18 yields an image that's a little easier to find things on, okay? But we're not talking about apples and oranges. We're talking about maybe the difference between a Macintosh apple and a kind of a delicious red apple or something like that. So gallium, for example, there is cyclotron-produced gallium, but it's mostly produced by these generators, which are expensive, and then it's complex, with the to make the radio tracer. So the fact that fluorinated radio tracers have a longer half-life, it means that you could even fly them from one location to another. Talk about rural areas. And also with gallium, sometimes our technologists get nervous because if a patient's running late, you might have too low activity to really have a good scan. With a twice as long half-life, well, if the patient's running late, people don't sweat it as much. Cons are having to do with chemistry. So the fluorine-18 chemistry is a little more difficult. There's more potential for instability. Again, this is possibly why the fluorinated products were FDA approved later, because the FDA really wants to make sure that you have a reliable product. And let's say you don't have a nearby cyclotron, then having a radiopharmacy with that generator is going to be really great, because cyclotrons are much more expensive to construct and operate than getting a generator.
Well, those are great points. I think another thing, and I'm curious to hear your thoughts, is what we see on the clinical side. And bear with me, this is a urologist looking at these images, which I encourage everyone to do, is to review the images with their imaging specialist. The quality of these images, which we'll show in a second, are incredible. There is some differences in urinary excretion and then timing of capturing the images. And as a urologist, I frequently catch myself looking right into the prostate, and I do see differences. From your level, for maybe false positives or, reading these studies, how much do you think urinary excretion really impacts, the differences in the excretion between these agents, your ability to read?
So in our opinion, I think there is a significant contribution of increased activity in the bladder due to urinary excretion, and your ability to see subtle lesions near the bladder, such as the prostate bed. So depending on the radiotracers, sometimes it's even quite high, that with even modern PET scanners, you may have some artifact in the rest of the pelvis that makes it hard to see even some nearby lymph nodes. So for my money, I would rather have a PET radio tracer with overall less bladder excretion. And that is why we're excited about the use of fluorofolostat.
Yeah, and I even see that when I look at the different images. It's pretty remarkable. Again, as a urologist, I go look at the pelvis and try to see it, and even I can recognize that there's a potential advantage. No comparative studies completed, but it clinically appears better. So let's just go to the next section and cases. How can PSMA PET imaging lead to treatment changes? This is kind of the fun of this. And I think I have the first case. I'll start off, and then I think, Dr. Schuster, you have a couple of cases that you saw. So this is my case. This is a guy we just operated on maybe less than a month ago. I don't even have a follow-up PSA. He was a 67-year-old man presented with high-risk stage 3C clinical T2A, Gleason 4 + 5 = 9. Pre-treatment PSA 4.8, significant stage migration, picking up, pretty high-risk disease. Based on guidelines, NCCN guidelines, anyone above unfavorable intermediate, I PET. And he had a tiny lymph node in the pelvis with early involvement. SUV was only 2.5. I want to ask you about that. And then we could clearly see the tumor in his left peripheral zone. I'm just going to flash the images and just get your opinion. I put the urology arrows in to show, where we see the lesion in the prostate, but also we see a little activity over in that left pelvic lymph node. What do you think about that, SUV of 2.5, or just that? How would you explain that to a clinician?
So it's really more about what we call targeted background or contrast rather than absolute SUV. SUV is an indication, it is a semi-quantitative indication of how much of the radio tracer is being taken up by a particular target or lesion. In this case, we could see, though there is fairly intense bladder, so I'm going to guess it's maybe, gallium or PYL, that left obturator lesion node, you could still see as greater than a nearby blood pool. And therefore, we would call that abnormal. Though again, I think that bright bladder can maybe take your eye away from it. So you have to, really look at these very carefully. We recommend when we're teaching courses on reader training is to window up and down. And that means that you're kind of setting your contrast and brightness like on your TV. And you just keep on going up and down, up and down, up and down. And that might help overcome, some of these limitations. So 2.5 means that it's not super intense, but it's intense enough that a good reader should be able to find it.
Yeah, so based on that, whether wrong or right, I took him to the operating room. We did a robotic assisted laparoscopic radical retropubic prostatectomy and bilateral pelvic lymph node dissection. I think where the PET scan helped me is that I knew he had no extrapelvic metastasis. He had a Gleason 9 cancer, so we could apply local surgical resection. And also equally important was I knew I had going into the operation to clear out that left side, and I would do a pretty aggressive lymphadenectomy as best as I could. Pathology revealed a grade group 5, T3A-N1. We got all margins are out. On that left side, we have 3 out of 13 positive. The largest metastatic tumor deposit was 1.1. And then on the right side, we did 2 out of 15 lymph nodes were also positive. Again, micrometastatic disease, and the largest kind of seen what we've seen in some of the Lighthouse data is that, the micrometastatic disease was too small for even a PET to image. And here was, basically 2 millimeters of disease at the most. So I think, clinically, this made me do a 28 lymph nodes, which is a pretty aggressive lymphadenectomy, and kind of, clued me in onto what we're dealing with, and also didn't let me do a surgery. If you go back to the Lighthouse data, where there's pretty high, metastatic rate in these high risk patients. So very helpful and very impactful in how I manage this patient.
So I'll take the next case. And this is also a high-risk prostate cancer, Gleason 4 + 5 = 9, had a negative MR and bone scan for, using conventional staging. And to the left, we see what we call our MIP image. This is photofolostat. And that's kind of like a spinning image where you can see the whole body. And we can see the bladder below as not very intense compared to some other PSMA radiotracers, but below that, and we see that on the image to the right, is the primary prostate cancer. Well, that's no surprise. We know there's primary prostate cancer there, otherwise we wouldn't be imaging the patient. But what we also see is some subtle uptake, and we can see the blue arrow in the left external iliac region. And if we go back and look at the MR scan, there's what we would call, and what I would call any day, a benign appearing 3 to 4 millimeter lymph node. That's really, really small. But when the patient went to surgery, that was the only node positive on a pelvic lymph node dissection, with one out of 25 nodes taken out. And when discussing this with the urologist, and this is where I think the imaging specialist and the urologist can form a really great team. The urologist told me that the PSMA scan was a big help, and that the one positive node did not look grossly abnormal, but just like on your other case, he made sure to remove all the nodes in the area knowing it was there, and was able to get that one node out. So I think this is where that high specificity comes in handy, where we can help guide the urologist to, let's say, fine-tune the surgery.
Yeah, I mean, that's a lot like my case, same thing. I don't have his PSA results. We just did this, but be very interesting to see, again, over time, as you start using these scans more and more, how we impact our BCR rate, our MFS rate, and our overall survivals.
Yes, definitely. And this final case is one of biochemical recurrence following low-dose brachytherapy. had a what we call a nadir PSA, dropped to 0.38, and then it went up to a PSA of 2.6. So this meets the definition of recurrence. And patient had a photofellostat PET. On the top images, we could see uptake. I'm only showing one, very intense left iliac node. And they were all 1 centimeter or less. But on the bottom images, and we could see also by the arrow, there was some subtle uptake. And this was on our clinical trial. First didn't know whether to believe this or not, but less than 5 millimeter, for lower SUV, this was 4.8 as opposed to 20, which is quite intense for that lymph node up in the left iliac region. So I thought, this is abnormal. I've never seen anything like this, but this is really abnormal. We need to further evaluate this. So we got an MR, and there was something there. Couldn't kind of nail down my colleagues in body imaging as to say this is benign or malignant. So I talked them into doing an MR-guided biopsy, and they're quite skilled at this. And indeed, this was prostate cancer, which is metastatic, coming into the ischial fossa. It's not a usual place that we find the lymph nodes or usual place of surgery. And actually, the patient did quite well with this. Then it became, radiation oncology, since it's biochemical recurrence anyway. And not only did the patient get proton therapy to the pelvis, as standard, but also to this lesion, and did quite well with a very low PSA. They did a short course of androgen deprivation therapy, but even after testosterone recovery, the PSA was still quite low. So this kind of gives the patient maybe more of a fighting chance, even though I think in the past, if we saw this kind of metastatic disease and wasn't able to target it, patient would just be placed on long-term androgen deprivation therapy, and that's it. And now we have a kind of a fighting chance, though more research needs to be done into this type of disease.
Yeah, this is a great case. The radiation oncologists love PSMA PET for that they can, boost these areas and direct it with the quality of their technology today. We're not going to talk about it today, but the whole area of metastasis-directed therapy is also changing the face of this disease. So with that being said, I just want to, start closing this out and talking about patient education on PSMA testing and results. I guess my question to you, Dr. Schuster, when your patients are coming to you, how do you explain why we need to use this advanced imaging, this very expensive technology?
Right. So the way I like to put it is that traditionally we've looked at anatomy only. And anatomy only gives you part of the picture. We also want to look at function and metabolism, because that gives us more sensitivity. So we are able to, I'll give an example. Let's say you have a light bulb, and you just look at the light bulb, but you don't know whether the light bulb is working or not. You see the shape of the light bulb, and you say, well, that's a light bulb. But by using this molecular imaging, we could then apply electricity to the light bulb, and you could see, well, is the light bulb turn on? Is the filament working, or is it not? So that gives us this greater sensitivity to really look inside the body, short of doing biopsies everywhere, which would not be really possible, of course.
Yeah, and I think that's the evolution that we're seeing. For the last 100 years, we probably started off with chest x-rays. We could see a lesion. We've moved on to CT chest. We get a clearer picture, a better picture of anatomy. And then we've transitioned to functional imaging, or PSMA PET, where we see a structure, and now we look at the cellular level, and we have increased sensitivity for detecting what that is, whether it is a metastasis or spread of prostate cancer outside the prostate. As far as in your center at Emory University, walk us through how you prepare patients for a PET scan. What's your team informing your patients?
Sure. we call the patient and, explain what they're going to go through. And these instructions are really not necessarily specific to PSMA PET. You don't need to fast for PSMA PET. But a different kind of PET, which your provider could order depending on your stage of disease, looks at glucose, and that you do have to fast. So all PET scans are not created equal. There's different radiotracers that we use, and depending on that radiotracer will depend on the instructions you're given. So that's what I would say. The take-home message is get those instructions and listen to the instructions, and just don't look up on the internet, oh, I'm having a PET scan, because it's really going to depend on what kind of PET scan you're having. But drinking plenty of water is actually pretty important for both.
Here's some more specifics. Anything you stress here?
Yeah, I would say, dress comfortably. Understand this is going to take a while. This is not like coming in, to McDonald's and getting your order. This is, it's going to take an hour, then you're getting checked through your vein. Okay, so if you tell, some patients don't have good veins. So if you let them know in advance, well, maybe they have kind of a specialist there, who can help with that. You're going to be in a quiet room, typically for this type of PET scan for about an hour. Okay, so it's not like you just get injected and go right on the table. So, set aside some time. If you have claustrophobia, even though these scans are fairly open compared to an MR scanner, some patients just have really bad claustrophobia. And knowing that in advance, asking, for example, your urologist, hey, can you give me a little something for that claustrophobia? Because that might not be available at the imaging center, depending, on how they're allowed to practice for these kind of things. Afterwards, drink plenty of water. You want to wash this all out of your body. I would say by the time you leave, radiation precautions are really minimal, and just listen if there's any specific instructions, from the technologist. And then these are not read right away, but typically they're read the same day. Okay, and then a report is issued. And so, your urologist or other care provider should have the report at the latest in most centers within a few days.
That's great information. Very helpful to, inform our patients as we send them over to the imaging centers what to expect. This has been an incredible time with you, Dr. Schuster. So much information. I'd like to thank our partnership with LUGPA. LUGPA is the Independent Practice Association, represents over 2,200 members, 25% of practicing urologists, 30% of urologic care in the United States. And one of the cornerstones of LUGPA is improving the quality of care through education like this. Also, this is just some great organizations that, your patients, or you can direct your patients to as trusted sources of information and resources. Zero, PCF, Prostate Network, cancercare.org, all great stuff. I would like to thank everybody for joining us today. Thank you, Dr. Schuster, for joining me today in the great discussion. I would also like to thank Blue Earth Diagnostics for their support of this important educational activity. Please remember to complete the post-test at the end of the session to secure your CME credits. Please visit medlive.com to view today's session along with other sessions on demand. My name is Dr. Jason Hafron. Thank you for joining us today.
In our upcoming UroNurse episode, we'll dive into the results of a recent survey that sheds light on the variations in prostate biopsy practices across different urology offices. Key topics will include the types of biopsies performed and who performs the procedure. What antibiotic regimens are used to prevent infection? What bowel preparation techniques and anesthesia preferences do you use? This episode aims to offer valuable insights into the diverse approaches that exist in prostate cancer diagnostics and how they impact patient outcomes. Join us next week on UroNurse.com.
All right, folks, we survived. I told you it was long, but I really thought this was such a great talk. I couldn't not give it the full time it needed. So no time for Q&A. Got to get rolling to our next show. Again, those of you that know, I do have the europatient.com Europatient podcast that comes on every Saturday after this show at 10:30 a.m. So we'll be going into that one next. If you want to throw some comments in how you liked it, go ahead, throw those in the comments. I can always review those later. And we'll see you next week because we're going to be continuing on with our prostate cancer awareness with that great prostate survey. Gosh, I got a great number of you guys that filled out that survey. If you haven't done it, go ahead and do it now. But I'm going to be compiling all that stuff and we'll be talking about it next week. So that will be with our experts. So join us next week for that lively talk about prostate cancer biopsy, the survey, and what we found. See everybody next week.